Thank you, Dr. Nizar. Thank you, the organizing committee, for giving me this opportunity to present the herpes zoster vaccination in adult, the paradigm shift. This is a disclaimer letter, as I'm not a GSK employee. So just a little bit about the varicella zoster virus. So it's one of the human herpes types. We know that we have many human herpes, example, herpes simplex, the varicella zoster, EBV, and CMV. And as we can see, the structure of the virus contains a double-strand DNA and surrounded by the glycoprotein, which is the main antigenic part which is used in the current approved vaccine. Now, in terms of the clinical manifestation of the varicella zoster vaccine, it causes two distincts of the diseases. The first disease is the varicella, or the primary chickenpox, and it used to be a common disease in a childhood before the vaccination era. Also, the other disease is a zoster, or herpes zoster, or shingle, which is a reactivation of the virus itself when the immunity is down during either the adulthood or during elderly. Now, once the infection, the primary infection happened, the virus goes into a latent stage, mainly in the dorsal ganglia, as most of the herpes virus family. Then once the immunity is down, the reactivation happen and a shingle or a herpes zoster happen. In terms of the incidence, it's very quite common disease. 1 in 3 people will develop shingle during their lifetime. The overall rate is 6 to 8 per 1,000 person year at the age of 60. In the United States, 1 million of people got shingle each year, 1.7 in Europe, and 1.5 in China. Now let's talk about a little bit about the clinical manifestation of shingle. The main acute presentation, the patient will develop with unilateral or dermatomal vesicular rash with a severe pain accompanying this presentation. What we fear more than the pain is the complication of the virus. We have the post-herpetic neuralgia. The post-herpetic neuralgia manifests as persistent pain beyond 3 months. So before 3 months, we don't consider a diagnosis of persistent or post-herpetic neuralgia. It's quite common as it affects 30% of patients with shingle. Now, herpes zoster ophthalmicus, of course, is a common or a quite common disease in the shingle entity, as it is manifests in 25% of the patient with shingle. As it surrounded the eye, we fear from iritis, keratitis, and eventually vision loss, which is a rare occasion. Other complication, it might be associated with disseminated disease as hepatitis, pneumonitis, neurological complication as meningoencephalitis, which is rare, Ramsay-Hunt syndrome when it involves the facial nerve and affecting the ear, Bell's palsy, and cardiovascular and cerebrovascular events as in case of cerebral angiitis. Now, can shingle reoccur after we have the shingle? The answer is yes. In the studies, 6 to 10% of patients who had shingle, of course, they will boost the immunity, but later on they are at risk of developing another attack of shingle in their future life. Talking about the burden of the disease, so the main culprit or the risk factor for the immunocompetent host is basically the age. So as we see in this graph, in the multinational studies, most of the disease after the age of 50 increased by even double or triple. Not only that, the post-herpetic neuralgia, the incidence increases after the age of 50. So age is the most culprit risk factor for developing shingle. Now, talking about the immune system, what is the pathogenesis behind the varicella zoster? The chickenpox will give will enhance the immune system and mainly the cellular immunity during the childhood. And this cellular immunity will remain patent during the adulthood. Now, there is interesting phenomena during the adulthood. The patient or the person might have experience with exposure with the varicella zoster virus, and this will enhance or increase the immunity against the virus with a silent or no clinical manifestation. But as you see later on in life, after the age of 50, the cellular immunity will decline in the phenomena called immunosenescence. And this is the main risk factor where the reactivation of the virus will develop. Okay, not only the age, so we have other risk factor in some of the meta-analysis. The main other risk factor with a comorbid condition include diabetes, chronic renal disease, steroid use, and autoimmune disease, malignancy, and HIV. In HIV, most of the patients who are not on antiretroviral therapy, they are threefold increased risk of developing shingle or herpes zoster. And this is a meta-analysis showing each risk factor, how common or how big the culprit of these risk factor to develop shingle. As we can see, HIV and AIDS is the most common to develop, about threefold. Malignancy and SLE also represent a burden of the risk factor of the disease. Of course, we have other risk factors like diabetes and chronic kidney disease, but it's not similar as other immunocompromised conditions. So digging more into immunocompromised, so as we said, HIV, solid organ transplant, SLE, around threefold. But how about stem cell transplant? So the bone marrow transplant or stem cell transplant is about ninefold higher in the incidence of shingles. So they are at more risk to develop herpes zoster than the other immunocompromised condition. Now, how about the pain of the shingle? Most of the patients describe the pain as a significant pain. What we mean by significant is more than 3 on the pain of scale out of 10. So 88% of patients describe it as above 3. 65% describe it as severe. And severe is what we mean is above 7. And around 16% describe it as the worst pain in their life. In this questionnaire for short form of the McGill pain questionnaire, the patient described the herpes zoster pain and the post-herpetic neuralgia even above the osteoarthritis and joint pain related to autoimmune disease, and interestingly more than a labor pain. Now, the most important other than the pain is the quality of life, because this is what we focus on mostly the elderly patient who develop shingle. 64%, they have sleep disturbance, and around 58% enjoyment of life and general activity cannot be done, and it affects the mood and the normal work eventually. Now, the treatment option, as we all or most of us know, we start the antiviral treatment as soon as possible, and it is within 72 hours, which should decrease the severity and the duration of the disease itself. We have a couple of options, either acyclovir or valacyclovir, and there is evidence behind to decrease the severity and the duration of the herpes zoster itself. However, there is no data that this antiviral medication can decrease the pain severity for post-herpetic neuralgia. Most of the patients who develop post-herpetic neuralgia, the medication here is challenging. We use neuropathic pain like tricyclic antidepressant, opioid, and only 14% of those patients will be satisfied with the medical treatment. Now let's talk about the herpes zoster vaccine, focusing about elderly as a risk factor initially. And why elderly? Because they are more prone to develop herpes. They are more prone to develop post-herpetic neuralgia and the non-pain complication, and also more to develop to be hospitalized. We expect that age 50 plus to live another 30 or 40 years. So the quality of life is important here. Hence, the vaccination should be offered this effectiveness against the shingle. And talking about the history of the varicella development, the first vaccine was developed in Japan with the name VOCA, developed in 1974. Later on in 1990, they used the same vaccine to prevent zoster. And this is a live attenuated vaccine, but the efficacy was around 50%. Now, in 2006, the Zostavax, which is again a live attenuated vaccine, was approved and introduced with a 69% efficacy in preventing the shingle. However, the long-term follow-up showed the rate of hospitalization and death is similar in between the vaccinated and the vaccinated group. Now, in 2017, the recombinant zoster vaccine or Shingrix was licensed for the elderly more than 50 years old, with an efficacy of 97% in preventing zoster. Later on, in 2021, the same vaccine was licensed for adult age more than 18 who are immuno or will be immunocompromised during their lifetime. Now, how about the vaccine itself? So Shingrix is a recombinant subunit. It's non-live attenuated vaccine. So basically, we have the antigenic part, if you remember the glycoprotein in the virus. So we use the glycoprotein E as an antigenic part together with the adjuvant system to enhance the immunogenicity of the vaccine itself. But how about the clinical profile? So we have two large multinational, multi-center randomized clinical trial. The first one called ZUI 50. From the name 50, they use patient above 50. And the ZUI 70, which they use the patient above 70 years old. In the ZUI 50, they included 16,000 people, and the ZUI 70, including 14,000. And the endpoint was measuring the efficacy against herpes zoster, post-herpetic neuralgia, and other complications. And as you can see here, these are the countries that were involved in the study. Now, in the ZUI 50, the overall efficacy of the vaccine was around 97%. And in the ZUI 70, for people above 70 years old, it was around 91% overall efficacy in preventing shingle reactivation. Okay, digging more into the vaccine and preventing the post-herpetic neuralgia. Again, this vaccine is not 100% to prevent shingle. However, if the patient develops breakthrough reactivation, it also shows efficacy against preventing post-herpetic neuralgia in those groups of patients. Now, the same patient or the population were followed up for a long-term complication. So after 4 years, up to 10 years, there is an interim analysis which shows actually the vaccine is still effective, which means we don't need a booster for the vaccine later on in life after 10 years. So far data, the vaccine is effective in 89% to prevent the shingle or to prevent herpes zoster reactivation. This is more digging into the comorbid condition on how the vaccine prevent shingle in each comorbid condition. For example, diabetes, the efficacy was around 91%. We have coronary artery disease, the vaccine was almost 97%. And in respiratory disorder, it was around 84% in preventing shingle. But how about the severely immunocompromised? As we remember, the bone marrow transplant, which are the most at risk to develop shingle, most of the patients who had received the vaccine, the efficacy was around 68% for the bone marrow transplant. In the hematological malignancy with immunosuppressive and chemotherapy, the efficacy was around 87% to prevent shingle. Now, how about the adverse reaction or the safety profile in the package insert? Mainly, it's local reaction as a pain or swelling. We have systemic manifestation, manifest as fever, shivering, headache, myalgia, and potentially GI symptoms. Now, the vaccine are giving in 2 doses series. So we give the second dose in 2 to 6 months after the first dose. If the patient came after 6 months, the action is just to give the second dose without repeating the series. And usually we combine or reconstitute both the adjuvant and the antigenic part. The vaccine is stored in the refrigerator, not to be freezed. It is giving an intramuscular injection. The contraindication usually is hypersensitivity. Usually, we try to avoid this vaccine during the pregnancy and during the active disease. For example, if we have active shingle, we try to wait until the virus or the disease fully resolved. Or if the patient has active fever or active viral infection, so we wait until the infection is completely resolved. Now, there is data about concomitant administration with other vaccine, example, influenza, pneumococcal, and Tdap. So there is no safety issue raised during those concomitant administration. And this study actually done in Riyadh, basically they monitor the patient who visited the primary healthcare in the hospital, and only 4% of the patient who are aged more than 50 years, they receive the vaccine. The elderly population aged more than 50 have been more than 44% from the overall population who visited the clinic. So they focus on mainly asking the patients if what is the limitation, mainly what's awareness about the vaccine. Even poor knowledge was also documented. So I think mainly we need more awareness and knowledge, not only to the public, but also to the physician to enhance our information about the vaccine itself so we can deliver the best care for the patient. And this is an interim analysis we are doing with my colleagues, targeting 1,000 patients. So far, we have 148 patients. And the reason behind not taking the vaccine, most of the patients, in around 42%, they just did not know about the vaccine. And in around 23%, they just say, I don't want to take the vaccine, so just leave me alone. And 17%, they were worried about the side effect. So as a conclusion, herpes zoster is a common disease affecting 1 in 3 people during their lifetime. Post-herpetic neuralgia causes debilitating pain. Post-herpetic neuralgia affecting 30% of patients who develop shingle. Elderly and immunocompromised patients are more prone to develop herpes zoster. And the RSV or the RZV is effective in preventing herpes zoster in patients above 50, and it's also licensed for immunocompromised patients above 18 years old. So data so far shows no need for additional booster 10 years post the vaccine series. With this, I end. Thank you.